Thanks for the planning faculty as well as the having me here today. I was asked to talk about renal denervation. I'm an interventional cardiologist at Wayne State University Detroit Medical Center. These are my disclosures. As the burden of hypertension has been increasing with almost 19% increase in the last 5 years, with expected 1.5 billion individuals in 2025 suffering from hypertension. In the recent EAC analysis or survey, there is a high burden of hypertension in Europe. I see it's very low in the United Kingdom, but pardon me for the small font, but I couldn't fit this better. And Estonia has really the highest hypertension prevalence. When we look in the US, also there is close to 400,000 deaths in the United States in 2013 due to high blood pressure as primary or contributing cause. American visited also the providers for hypertension issues more than 55 million times, and control remain unacceptable in more than 50%. Non-adherence, which is the most common issue, is common from 40 to 50% due to patient compliance. A little bit of anatomy, now we understand after all these trials that has happened and how simplicity kind of in the beginning showed negative results. As you see there in the anatomy, there is more adrenergic nerves in the branches of the renal artery compared to the main trunk. This is one of the things I would like you to keep in mind as we proceed during this presentation. And this is also kind of a heat map of the nerves. And as we are going distal, there's higher probability of targeting nerves if we go distal in the renal artery, and especially if you are treating beyond the bifurcation of the renal artery. So if the early iteration of the catheters, the number of ablation has been correlating with a better treatment. So the operator has to ablate in 4 quadrants and to make sure all 4 quadrants are ablated, which is, you understand, technically this can be sometimes undoable or hard to do. So this is the Simplicity Flex catheter. It has a single electrode catheter with 120-second energy delivery and vessel diameter from 4 to 8, and that go through a 6 French compatible, and deflector goes through 4 French catheter. But the new iteration, the Simplicity Spiral Catheter, has a multi-electrode, which is provide more burning or more energy delivered throughout the artery, as well as has a shorter period of time, 60 seconds. You have more probe on the more electrode on the catheter itself that can kind of burn simultaneously. And the vessel diameter again, same 3 to 8 millimeter, and it's over the wire 4 French, which can allow further delivery of the catheter distal to the branches to kind of deliver more therapy distally, where I showed you earlier, which makes sense to have more ablation done distally. Also, the device kind of has a kind of smart feedback mechanism where electrical stimulation is detected, and the catheter will detect any hot spots throughout the ablation, and these are hot spots areas where should be ablated, which means that we are getting more specific, delivering the energy where the area of interest I would like to ablate. There's multiple catheters right now in development or already developed, Spiral 1 catheter, and you have a Boston Reinforce and St. Jude and light hypertension. As you see there, they come in different delivery system, but so far, I mean, the Spiral 1 catheter has a sequential, has a distal branches and proximal as well, which is give it a bit advantage compared to other that focus on the main trunk only. So sustained efficacy, I mean, as you see there, comparison between the 2 catheters, blood pressure kind of maintained to be low with the average of minus 12 points for millimeter of mercury at 1 year and 2 years. And this is shown again in the Spiral. So in terms of safety, which is one of the main concerns for these new catheters, as you see, there is no death or any issue related to the vascular injury, dissections, or any narrowing in the renal artery or vascular complication. In terms of the safety result as well, which is renal artery stenosis or stenosis due to ablation, you are worried about scarring. Even at the follow-up of 1 year, there is no evidence of stenosis. This is by angiography as well as ultrasound. And resistance study, which is renal artery branches remain unchanged following RDN or renal denervation at the follow-up, with the diameter being maintained throughout the follow-up as well. One of the new technologies has been presented lately in Europe is the alcohol-mediated denervation using the Pergerine system. It's where it's an alcohol delivery system, similar to alcohol septal ablation, but now you are with a micro needles kind of get deployed from the catheter and inject a 0.3 to 0.6 milliliter of a pure alcohol to kind of burn throughout the renal artery. The early results has been presented recently in Europe as well as in the mandated break-in trial at CRT at the follow-up of 12 months. There is a maintained kind of control of hypertension, but I'd like you to pay attention to the number of patients that has been enrolled, which is small, but still it's a promising device and promising results. But you can see there's a number of patients who are achieved therapy, but there is also a small number of patients did not benefit, the blood pressure went the other way, but it's still considered a small number. Again, there was no complication in terms of vascular injury. Dissection happened in 2 cases. The presenter mentioned in his presentation that the 2 operators were not educated and they kind of basically pulled the catheter out while the needle were deployed, which definitely will cause injury. But otherwise, there was not flow limiting on follow-up. And there is an ongoing right now, it's called target blood pressure. It's happening in 20 centers in Europe, to study the patient off medication. So this will be a new device studying patient on off blood pressure medication. So going to practice now, what do you need to show before renal denervation can be used in clinical practice? As we know, there is a certain number of responders. As you see, there is a percentage of patients with more than 5 millimeter mercury decrease. Renal denervation was effective in 66%, but the rest did not. So why this cohort of patients responded compared to other? Is there a biomarker that we're missing? Is it anatomical, or is this because of the patient characteristic or ethnicity? This is need further investigation. Again, similarly here, we show in the Lancet 2017, showing again there is a certain number of patients responding, but other are not. So there is some more fine-tuning in patient selection for these devices. The other question we have in mind is the blood pressure lowering is enough. Are we just treating the blood pressure, or are we changing heart outcomes like death, myocardial infarction, heart failure, stroke? This is again shown in relative risk reduction, which is significant in studies, but again, this has not been of area of a primary endpoint in these trials. So reduction of heart point, again, this is something of interest. And one thing I would like to bring to your attention, even in SPRINT trial, allowing patient with medication did change in the heart endpoints like MI, stroke, and death. So does the catheter can do that? So in summary, is really the renal denervation is coming? Yes, there is a lot of catheter coming, and we know now we're selecting more patients for these devices, and probably we understand this mechanism and anatomy. So patient selection is very important. Being familiar with the device and indication is crucial. And low-risk hypertensive and outcome study may be needed to address the long-term efficacy and durability of these therapies, as well as studies to evaluate the renal denervation benefits beyond blood pressure lowering, as I mentioned, for heart endpoint. Thank you so much for your attention.
Thank you for that nice presentation. We're going to move on to keep on time here, and I'm going to invite one of our course directors, Mehdi Seshapur, to come and talk to us about deep venous arterialization for no-option CLI patients. Is there hope for this procedure?
Thanks, Manish. Appreciate everybody being here, and I have no conflict related to this presentation. Actually, just stepping up for Stephen Coombe, who was supposed to give this presentation, but he couldn't make it, so I apologize if it's not as polished. So what are those no-option patients? If you ask any operator, are you ever not able to intervene or revascularize the patient, most likely you hear that never happens to them. But it turns out that, when it comes to CLI and limb salvage, there's a group of patients that despite aggressive revascularization, despite bypass surgery or endovascular therapy, are not able to be revascularized. Typically, these patients end up in wound care, and this could last for a long period of time. Some of these patients are there for months and years. And eventually, they end up with amputation or they die. As you know, there is a high risk of mortality. So we estimate somewhere between 14 to 20% of patients with critical limb ischemia that require revascularization have no options, meaning that they cannot get blood flow to the leg. So the question is that if you don't have a bypass option and you don't have an endovascular option, is there something else that we can do? We know that the blockages are in the arteries, but is there a way for us to divert the blood flow from the artery to the vein and make the venous system become the conduit to deliver oxygenated blood to the foot? And the way this procedure is done is that we have access in the vein and in the artery. There are two catheters that come up, and they kind of start talking to each other, as shown here. We then stick a little needle, and many of you may have used the Outback device or the Pioneer device. This is very similar. We stick a needle from the artery into the vein. Once that's done, then the venous system is kind of wired with a wire, and here we are going through the valves, and the wire has passed through the venous arch in the foot. We then use a valvotomy to destroy the valves, because again, we want the blood flow to be going towards the foot, not away from the foot. Once we have done that, we are then ready to make the connection between the artery and the venous system. And remember, these are deep veins in the calf. So once that is done, there is a stent graft that's placed in the vein from the ankle up to the site where the connection between the vein and the artery was made, as shown here. Then a tapered stent-covered graft is placed in this area, and now you have basically deep venous arterialization, meaning that we have taken the blood flow from the artery into the vein, and now we're going to use the venous system as a conduit to transfer blood to the foot. So what is the data? That's the procedure. What's the data? Well, there is a number of studies that have been done. Obviously, we don't have thousands of patients that have undergone this procedure. It's complex. However, as I've shown here, there is a 7-patient first-in-man that was conducted in Singapore with Dr. Stephen Coombe, who was supposed to do this presentation. Following that, there was a CE mark of the study with 36 patients. And then we brought this study here to the United States in Promise 1, which started with 10 patients, and then the FDA gave us an expansion to 35 patients. And we were part of that study. So the key endpoint for that study was 30-day and 6 months freedom from amputation. Remember, every single patient for this study is scheduled to get a major amputation. And this is after being evaluated by a rigorous committee of multidisciplinary vascular surgeon and interventionalists and radiologists, operators that deal with this kind of a condition. We also look at endpoints such as secondary endpoints such as patency, wound healing, technical success, and procedural success. Again, these are people with Rutherford 5 and 6. They had to have wounds, not even Rutherford 4. These are no-option patients getting ready to have a major amputation. And those were some of the hemodynamic follow-ups in these patients. This is the baseline characteristics of some of the patients. You can see that about 60% of the patients had Rutherford 5, and about 40% had Rutherford 6. These are folks that actually need a minor amputation because they already have gangrene. Very complex group of patients, 80% with diabetes. I'm not going to go through all of them. But very sick group of patients, if you can imagine, no option CLI patients. There was 100% technical success, 100% survival at 30 days, and 100% amputation-free survival at 30 days. At 6 months, they had a 100% amputation-free survival and wound healing, which is to me the most important, because you may not get an amputation, but have your wounds for months and years. To me, that's not success. 70% of the patients had complete wound healing. These were patients that were scheduled to have a major amputation. So with that, I just want to quickly show you a case, and hopefully I catch up on the time. This is a 59-year-old patient with Church-Stroud syndrome and prior left lower extremity amputation. This was a patient of mine in my previous institution where I treated her endovascularly. She was referred for bypass. She was not a candidate. She has lost her leg at that time. This happened in September of 2017. She was doing okay for a couple years, and then she showed up with new wounds on the right side. Again, she has vasculitis, as I mentioned earlier. She underwent an angiogram in now presenting with wounds on the right leg, again, having lost the left leg. You can see that she has a very decent inflow. The common femoral looks great. The proximal mid-SFA look fantastic. The popliteal looks really nice. But then you get to the the tibial arteries. There is still decent tibial flow. And then once we get to the foot, this is what we see. And let me give you a chance to catch up with this. And this is really what we call the desert foot. This is where we call, where there is no area where you can bypass, there is no area where you can really do endovascular, and because of significant calcification, because of our vasculitis, we couldn't really revascularize this arch and the distal foot. And this is a lady that already has lost a leg. So again, I tried to save this leg. I couldn't do it endovascularly. This was her situation. She presented in January of 2018 with a TBI of 0.28. Please look at the waveforms. And after the endovascular work that I did and the wound care, you can see that the wounds are getting worse and she is not healing. And I think Dr. Carmen was also helped us out in the wound care in this patient. So at this point, we were left, this is a no-option patient. We went to the company, we said we want to put this patient into the trial. They said, well, sorry, this patient has vasculitis, this is exclusion, we cannot do it. So finally, working with the FDA, with the institution and the company, we were able to get it as a compassionate use, and we were able to offer this patient, who is the first patient in the world to get a compassionate use deep venous arterialization using the technology from the company to do this procedure in April of 2018. And this basically summarizes the procedure and the cartoons that I showed you. So here we are again, the tibial arteries. We typically like to use the posterior tibial artery if possible. So we're coming down the posterior tibial artery. We will then connect the posterior tibial artery to the posterior tibial vein. Once that's connected, a wire is passed through. We use a valvotomy to again destroy the valves here all the way to the arch, but not including the arch. Once that's done, stent grafts are placed from the ankle all the way up to where the connection between the posterior tibial artery and the vein is made, and now you can see the flow. Typically, you don't see a good blush after this procedure. There is a period of time for recovery of about 3 to 4 weeks before we see good improvement. But I do like to show you the hemodynamics, which are amazing. So remember, in February of 2018, she had a TBI of 0.18, and these were her waveform. This is her wound now in November, about 4 months after the procedure. She had a minor amputation of her toe. Her TBI is now 0.54, and these are her waveforms. I put the hemodynamics just to show you. We really don't understand what's happening, but something is happening. And she has now healed, and we were able to save her leg through this procedure. So far at University Hospitals here in Cleveland, we have done 5 patients. 2 of them had complete wound healing and have done fantastic. 2 of them ended up with major amputation despite our effort, and 1 patient is currently under wound care. So we have had about, I would say, 50% success, which I think for folks that are scheduled to undergo major amputation is huge. Thank you.